Welcome to Sky TV. I'm Chandan Devareddy from Emory University School of Medicine, and I'm joined by my colleague and fellow member of the Heart Team, Vinod, Professor of Surgery, also at Emory University School of Medicine. And what we hope to discuss with you today is a review of a lot of the groundbreaking trial information that has come out this past year, evaluating the performance of transcatheter aortic valve replacement, specifically the SAPIEN 3 device versus surgery, and how best to interpret this data, incorporate it into practice, and talk about future steps from here. Transcatheter aortic valve replacement technology was first tested in the intermediate risk population with the PARTNER-2 trial. The PARTNER-2A trial looked at intermediate risk patients that were differentiated to either transcatheter valve technology or surgery. Within the transcatheter valve cohort, patients could undergo TAVR either through a transfemoral approach, which is preferred, or through alternative access, either transapical or transaortic. Patients were one-to-one randomized between TAVR versus surgery. And this trial was then followed later by the PARTNER-2 S3I trial, which Dr. Thorani will talk about in just a few minutes. But the PARTNER-2 trial overall involved approximately 3,000 patients, and with the PARTNER-2A trial involving 2,000 patients that were subsequently randomized. If you look at the composite outcome with the PARTNER-2 trial, all-cause mortality and disabling stroke, surgery and TAVR was equivalent at the 2-year outcome. But when we dissect into the data a little bit further and just look at the transfemoral arm, the outcomes were actually better for patients undergoing TAVR when compared to surgery. And this is relevant because most of the patients, 80+% of patients undergoing TAVR, are being performed through a transfemoral route in this trial. And in current clinical practice, this really represents the majority of patients that are undergoing TAVR now. Based on this data, this was then followed by the PARTNER-2 S3I trial, and I'll let Dr. Thorani go into more of the design of that trial.
First of all, Chandan, thanks so much for having me here. It's nice to be able to be on this show with you, but also be in the Heart Team evaluation of patients together. So I think it's impactful on 2 different levels. So what we were able to do in the PARTNER-2 SAPIEN 3i trial was we took the same design. It was the same review committee. It was basically one followed the next. What we were able to do is not perform a second randomized trial comparing SAPIEN 3i to the PARTNER-2A patients, but we were able to take the surgical patients from PARTNER-2A and do a predefined FDA adjudicated analysis of the SAPIEN 3 valve against the or comparison with the PARTNER-2A surgical patients. And we were able to break them down into the TF and the TAO TAVR subgroups, as you can see here on the slide. And we had the primary endpoint of all-cause mortality, all stroke, and moderate aortic regurgitation at 1 year. When we looked at the thermometer graph analysis of the primary endpoint and also the constituents of the primary endpoint, we were able to see that TAVR had better outcomes when we looked at the primary endpoint. And when we broke it down to all-cause mortality, TAVR also was better compared to surgical valve therapies. And when we looked at all stroke, it also had a better outcome than did surgical valve replacement. When we looked at moderate aortic regurgitation, we saw that surgical valve replacement did better than transcatheter valve therapy. So this was very important for us to look at the subgroups, but also the primary endpoint. And what we're able to see in all-cause mortality is that you see a very low 30-day mortality of 1.1% in those undergoing SAPIEN 3. You're seeing a 1-year mortality of 7.4%, one of the lowest that's ever been published and reported in especially intermediate risk patients using a transcatheter valve therapy. So you see that those patients at a stroke rate of 1% at 30 days and a cumulative stroke rate of disabling stroke at 2.3% for 1 year. You can see early on that surgery has higher mortality and stroke rates, and really the graphs and the lines are really parallel after about 1 to 2 months. And so I think that's an important aspect to note, that it's the early 30-day mortality and disabling stroke that separates really transcatheter valve from surgical valve replacement.
I think what's important to point out, how were these strokes defined in the trial?
And quite interestingly, in PARTNER-1, we did, just because it was the first trial ever done on transcatheter valve therapy, we really didn't have neurologic adjudication. And what's different about the PARTNER-2 studies is that we had really good neurologic adjudication, and we feel very confident that these are really well-defined definitions and evaluation of stroke. What we also saw was that in those patients who had the PARTNER-2 SAPIEN 3 TAVR valve, the mean ICU stay and also the mean hospitalization length of stay was very short. And so it's quite remarkable what we're able to do. And we've actually made a lot of progress since then, where we're doing a lot more minimalist type of TAVR, and they're going home within 1 to 2 days.
I think there's interesting data that's been presented at TCT suggesting that quality of life is sustained and possibly with a transfemoral approach improved with patients undergoing TAVR?
Absolutely, and you know, roughly over 80% of patients are in the SAPIEN 3 now are being performed transfemorally, and I think that even though the data that we show for the SAPIEN 3i has both transfemoral and non-transfemoral pathways, I think that when you look at the transfemoral patients, they do even better than the data that's being represented as an overall 1,000 patients.
So currently, we've got this device, SAPIEN 3, with a robust data set through PARTNER 2S3i. The FDA has approved this valve for what's deemed to be patients at intermediate or higher risk. So currently, how are you defining intermediate risk?
So I think the best way to do it is to see the patient, calculate an STS score and see where that defines, but it's not just the STS score, it's an entire evaluation of the comorbidities and the frailty in aspects that are not even in the STS score, like liver disease or a porcelain aorta. Specifically for intermediate risk patients, I think that it's important for us to evaluate these patients together, add the STS score, the comorbidities, and make a team decision on what we think is the best aspect for this. And if the patient is low risk, then we'd like to take them into a low risk trial. If they're medium risk, a lot of these patients are now going into a TAVR pathway.
So some providers, when they hear intermediate risk, say, well, that must mean the 30% of patients in the middle of the risk spectrum. What have you seen as far as what defines intermediate risk with TAVR patients in this trial versus what you may see in the STS surgical literature?
Yeah, that's a good question. We looked at 142,000 patients in the STS database, but that study ended around 2010, 2011, so there's been a lot of progression and movement. We found that 6% of all patients were high risk by just an absolute STS score of greater than 8. We noticed that between 4 to 8, it was 14% of patients of the 142,000, and 80% of patients from that study had an STS of less than 4. So I think that we're now starting to see for the first time use of transcatheter valve therapy in lower risk patients and intermediate risk patients, which will be quite interesting to see how we follow these patients.
So when we look out to the future for transcatheter valve technology, where do you see this heading?
I see that this will continue to go in lower risk patients. The TVT registry in 2015, the median score, STS score was 6.3. So we're already seeing creep into the STS categories. I think it makes a big decision on what happens with durability of the valve, which so far we haven't seen very many in our center. We've done 1,600 cases and haven't seen very much structural valve deterioration. I think we need good data with the low risk patients. And I think that over the next 5 years, we're going to see a paradigm shift potentially for what happens depending on what the low-risk trials show us.
Now, the SAPIEN 3 is not indicated in the low-risk population, but there are clinical trials currently ongoing and enrolling patients to test that hypothesis. So when we see patients in the heart clinic and we're offering the decision between TAVR and surgery, right now, we'll say, you know, if we can do it through the groin, TAVR technically offers you a better option than surgery as far as stroke and mortality in the short term, and appears to be sustained at least with the durability data that we have so far. Are there any other intricacies of how that conversation has changed for you?
Well, look, I think so, and I like the way that you and I do this. And in fact, last Monday, if you remember, we had 3 patients who were relatively low to intermediate risk. They were somewhere bicuspid. Some of them need coronary disease. And we decided to take 2 of those 3 patients towards surgical valve therapies. And I think that robust interaction discussion is really what's required to do the right thing for the patient. And that's why we have to concentrate on not what the interventionist wants or the surgeon wants, but what's the right thing for the patient. That, to me, is the gist of what all of this is about.
Thank you so much for joining us with Sky TV, and thank you for your attention.
It's my pleasure.